Fed?
Oui, bonjour. Bonjour tout le monde. Hello.
Bonjour. I think
Hello.
we will start. We will start.
Yes.
We start in 10 seconds. Okay.
Okay.
So good afternoon from Morocco. Good morning, good afternoon, and good evening, wherever you are. We hope that you enjoy your day and happy Eid day. And once again, we are online for the 30th edition of the Morocco with webinar series. Welcome to all speakers, Professor Zouad Bakhti from Algiers, Professor Issam Shail from Riyadh, Saudi Arabia, and Professor Olivier Kane from Nancy, France. Welcome to our panelists. From the second city of Benin, Parakou, Dr. Kizito Kenam. From Casablanca, the well-known pediatric neurosurgeon in Morocco, Professor Mohamed Ashouri. And from Rabat, my colleague and friend, Professor Mustafa Hamama. On behalf of the Moroccan Society of Neurosurgery, welcome to all participants. Good evening, Professor Najir Abedi. Good evening, Professor Lakhdar. You have the mic. Thank you.
Thank you, Fed, for your great job that you are doing for this series of webinar. And dear colleague and dear friends, we are really very pleased and honored to receive you during this 13th webinar of this second series. And I would like to thank especially the guest speaker, Professor Shail from Arabia Saudi, Professor Olivier Klein from Nancy, France, and of course, my dear friend and excellent friend, Saad Bakhti, Professor Saad Bakhti from Algeria. And of course, I would like also to thank our panelists to accept our invitation. Our young friend from Benin. I'm just asking Fed a few minutes before that how many years that you are coming back, and I thought that it's only 4 or 5 years, and he asked me that it's 10 years. It's a long time. So we are very happy to know that you are 10 years there, and you are professor assistant currently. My congratulations for this excellent curriculum. And also I would like to thank Professor Ashouri from Casablanca, our neurosurgeon, pediatric neurosurgeon. He's among the rare pediatric neurosurgeon, because as you know, in Morocco there are no pediatric neurosurgeon. All the neurosurgeons are dealing with the pediatric cases. And finally, my colleague Professor Hamama, he works in Ibn Sina Hospital, and he works with us in the same hospital. I mean Sheikh Zayed Hospital. So welcome again, the floor, it's yours. Fahd, you can start to introduce our first speaker.
Yes, our first speaker is Professor Olivier Klein and Professor Kenam from Benin, Dr. Kenam Kizito first. As you said, he's neurosurgeon and he's assistant professor of neurosurgery at the Department of Neurosurgery in Parakou. He is the first neurosurgeon from Benin who was trained in WFNS Rabat Reference Center, followed by many other colleagues. He returned in Benin to Benin in 2010 and spent 6 years in Cotonou before becoming assistant professor at the second city of Benin, Parakou, at the Department of Professor Fatigba. He is also treasurer of the Benin Neurosurgery Society. Please welcome Kizito, and please will you introduce Professor Olivier Klein. Thank you.
Thank you very much. Thank you, Professor Abadi. Thank you, Dr. Darkawi. I'm pleased to introduce Professor Olivier Klein from France. And what can I say? Let me tell you that Professor Klein is born in October 7, 1970. He is the father of 5 nice children. He's a pediatric neurosurgeon and the head of the service of pediatric neurosurgery at the Surgery Hospital of Nancy in France. He's involved to training at the Nancy University Hospital concerning adults and pediatric neurosurgery. He participates to the validation of ESPN course and pediatric neurosurgery. He was before at the Necker Enfant Malade Hospital Pediatric Neurosurgery Service in 1999 and went after to London to the Great Ormond Street Hospital of London from 2006 to 2007. After that, he worked at Children's Hospital of Marseille, well known as La Timone Enfant Pediatric Neurosurgery in 2007, and was graduate as professor of neurosurgery in 2011, and then became a head of pediatric neurosurgery service of Nancy since 2013. His main interest is tumor, spinal dysraphies, including fetal counseling and fetal surgery, craniostenosis, Chiari malformation, and syringomelia. He was involved to more than 60 publications and presented 70 oral communication in a great meeting of neurosurgery. Despite all these words, I can say that he's a wonderful man and was interested also by philosophy and is a great writer such as especially detective novel. Thank you, Professor Klein, for accepting to participate to this webinar. Thank you.
Thank you, Kizito.
You're welcome, Professor
Nice
Abadi.
word.
Thank you.
Olivier?
Thank you very much. Thank you very much for this kind introduction. And thank you to all of my friends from Morocco. Thank you, Najia. Thank you, Fad. Thank you very much for your kind invitation. It's a real honor for me to talk about arachnoid cyst in children. So we will move to the presentation. The definition does not really differ from the original one. It's arachnoid membrane filled by CSF. It can exist wherever arachnoid.
Professor, excuse me, Professor Olivier,
Yes?
will you share?
Sorry, you have to share your screen.
Slide?
So I will share it. Oh, all right. Is it okay for you? Yes.
Yes, it's okay. Thank you so much.
Thank you. So I carry on. It can exist wherever arachnoid exists, and mostly in the vicinity of the basal cisterns, without communication with ventricles. And arachnoid cyst is most of the time unique, nearly 19% of cases. It is an abnormality of arachnoid development that begins very early during the first trimester. Other causes, as we all know, are trauma, infections, and so on. This is a very interesting paper, intracranial cyst. That's only 1% of all intracranial lesions. And among this 1%, you have 18% of arachnoid cysts. One of my mentors, Richard Hayward from Great Ormond Street Hospital, said these children may be vomit. That's victim of medical imaging technology. So is it true? I don't know. The question remains open, and we will try to answer this question all around this talk. Half of them are located on the Sylvian fissure, with other localizations, suprasellar lesion, triangle, quadrigeminal cistern, in the region of the cisterna magna, vermis, and interhemispheric fissure, and the convexity. Radiological characteristics, I mean, we all know that, but these cysts are hypo T1 without gadolinium enhancement, hyper T2, hypo diff in diffusion, and hypoflare. The differential diagnosis is stroke, particularly from the MCA artery, or porencephaly. Very typical is this arachnoid cyst from the convexity with a thinning of the calvarium, the cranial boat, and that's the operative view of the same cyst. Suprasellar arachnoid cyst, we will go to them one by one, may be revealed by hydrocephalus or precocious puberty, or very rarely, but classically, with bubble-head doll syndrome. Most of the time, they are discovered, they are diagnosed incidentally. Again, suprasellar arachnoid cyst, it's from a paper that we published some years ago. In fact, it was a shaken baby syndrome that developed 6 or 7 months after a huge cyst, huge suprasellar cyst with hydrocephalus and with the bulging of the cyst through the foramina of Monroe. That's the picture was done, was taken during treatment, endoscopic treatment. So we choose endoscopic treatment with a good result, because 3 months after, we observed a decrease of both the ventricular dilatation and the cyst itself. Interhemispheric arachnoid cysts, you must be very cautious when talking to the parents, because most of them are associated with other brain abnormalities, mostly from the corpus callosum. So, for example, partial or complete corpus callosum agenesis. Here is an example of interhemispheric cysts, pre-op and post-op. When we are faced with so wide cysts, we often prefer to go to shunting rather than endoscopic techniques. Pineal arachnoid cyst is benign, not in the vast majority of cases, is benign, but a cystic lesion on the pineal region is benign in the vast majority of cases. The problem is it can be a diagnostic trap, and it can be mistaken for tumors, because a single cyst can have contrast enhancement, septa, lobules, and the differential is a pineal tumor secreting or not. Here you are 4 examples of purely arachnoid cysts of the pineal region. They are not tumor. Also, there is a contrast enhancement on 2 of them on the right. And you have, it's very important to have a good neuroradiologist to help you from to make the differentiation between a tumor and an arachnoid cyst. If there is any doubt, then we go to the tumoral marker, alpha fetoprotein and beta HCG. Arachnoid cyst of the Sylvian fissure, half of them are located around the Sylvian fissure. The first message is these cysts are an acquired condition. In the series from Alain Pierre Kahn, 54 fetuses with arachnoid cyst, there was only 1 Sylvian arachnoid cyst. In my practice, we are a center of reference for prenatal diagnosis, and we see many cysts on prenatal ultrasound, and I see none during the last 10 years. So Sylvian fissure or temporal arachnoid cyst is an acquired condition. It's not a congenital one. We use a very practical classification called the Galassi classification. And type 1 is a cyst limited to the anterior part of the posterior fossa. Type 2 with an extension along the lateral fissure with displacement of temporal lobe. And type 3 is a wide cyst, full fluiding the entire temporal fossa and much more most of the time. It is important because Galassi 1 almost never enlarge. Galassi 2 can enlarge. It's a possibility, also rare, and you can face questions of such neurodevelopmental delay and treatment of or not. Type 3, we are much more aggressive surgically because this type of cysts usually enlarge and usually has an important mass effect. We will see that. So that's a Galassi 2, and on the right you see that there is a cyst rupture with subdural effusion, and Galassi 3 with much wider cyst. Again, Galassi 3, we will see later on the same child. Again, Galassi 3 with mass effect, and you will note the vicinity of the basal cistern. So the natural history. It is important to bear in mind that most of them are asymptomatic and remain asymptomatic on the long term. Talking about prenatal diagnosis, the vast majority, if not associated with other anomalies, remain clinically silent, do not evolve, or even frequently, I don't know, but sometimes regress. And that's very important. They are compatible with a normal life, whether requiring treatment or not. Here is the evolution of case Galassi 2-3. I saw the child on July 2009 with this bulging on the calvaria with a displacement of the lateral part of the orbit. The family refused surgery and came back to my office 5 years later with a catastrophic situation. The cyst was much wider, the mass effect was much more important, and the displacement of the lateral part of the orbit as well as the orbit itself was important. So in these cases, we recommend shunting and not endoscopic technique. Usually they are not sufficient to treat this kind of cyst. But obviously, in this case, at the time of July 2014, we had to go to much invasive techniques with orbital reconstruction and with we have to put in a shunt in the cavity as well. An important study, more than 11,000 children, among them 309 arachnoid cysts, which is probably the prevalence of arachnoid cyst in the pediatric population, 2.6%. So it's rare, but not so rare situation. Among them, the natural history was known for more than 100, with a follow-up of 3.5 years. 11 increased, 13 reduced, and 87 remained stable. Another story, 200 children, CT or MR were done for other reasons than cyst follow-up. And you see the association of headaches, 45%, to some, if you look at the literature, you will find sometimes 80% of association with headache. Anyway, surgery was recommended only for 15% of cases. And they discuss association with epilepsy and the problem of neurocognitive delay. So headache, 45%, and you see increase in size, 3.5%, hydrocephalus, 4.5%, and rupture, 2.5%. Talking about headache, 25% were true migraine, and 74.5% were classified as tension headache or unclassifiable headaches. For the whole series, symptoms leading to surgery were mostly symptoms of intracranial hypertension. Arachnoid cyst and epilepsy. This is a very important paper. 27 patients with Sylvian arachnoid cyst. 17 of them had neurological symptoms that could be in relation with arachnoid cyst, and 7 had seizures. But when we look at the files from these children, you will see that 6 had predisposing factors to seizures: birth anoxia, kernicterus, meningitis. And in addition to that, the localization of the seizure were not in correlation with the localization of the arachnoid cysts. So there is a dissociation between a structural and a functional condition. Also, I'm sure that all of us had sometimes a doubt between a relation with epilepsy and some arachnoid cyst. The prognosis is independent from brain deformation, cyst volume or cyst localization, but it's dependent from brain integrity. Brain abnormalities, corpus callosum agenesis, chromosomal abnormality, and so on. Let's go now to the posterior fossa. Cystic malformation of the posterior fossa is a very difficult nosological approach. You have true arachnoid cyst, which is our topic today, but some cystic malformation that can mimic arachnoid cysts, such as Dandy-Walker malformations, vermis hypoplasia, and megacystoma magna, which is just a variant from the normal. So, a posterior fossa arachnoid cyst, here again you will need a good neurologist to be sure that there is an arachnoid membrane around your cyst. The cyst does not communicate with subarachnoid space and neither with the fourth ventricle. The vermis and the hemispheres are normal. Most of the time it is diagnosed for other reasons, but sometimes you can be faced with hydrocephalus. So that's a real arachnoid cyst, that's pre-op. Again, here again, for this very, very wide cyst, we go to shunting and not for direct approach. But we use it sometimes if there is a failure of shunting, for example, but not on the first line. Here again, an important posterior fossa cyst. It was treated by ETV, as you can see on the left, on the side on the left, but it was not sufficient. And 1 year after, we put a cystoperitoneal shunt to treat, to better treat this huge cyst. Another example, prenatal diagnosis. We see many posterior fossa cysts on the prenatal diagnosis. Here is an example. Also, someone could say that it's a persistent Blake's patch cyst. Here again, some example of prenatal diagnosis, posterior fossa arachnoid cyst. CP angle, Dandy-Walker malformation. That's not my talk today, but sometimes it can be confused. with arachnoid cyst, which is a completely different problem, as well as Dandy Walker variant. Among differential, of course, this is not an arachnoid cyst, this is the cerebellopontine hypoplasia associated with lissencephaly. Megacysternum magna, that's very important not to confuse it with a true arachnoid cyst. It's only an enlargement of the cysternum magna. You cannot see any membranes. It's important to have cis sequences on the MR. There is a communication with subarachnoid space. There is a normal cerebellum. And sometimes, if there is an invagination of telachoida, we can discuss the persistence of Blake's Potch cyst. This is a completely benign malformation. Here you are two examples of megacysternum magna. Here another one, diagnosed prenatally. How to treat this cyst? Always remember, the great majority of cranial arachnoid cysts diagnosed pre or postnatally require no surgical treatment. That's very important to remember. Surgery, we can do cyst fenestration by microsurgery, fenestration to the ventricle, to the cisterns, excision of cystic membranes, cystoperitoneal shunting, endoscopy, for example, cystoventriculostomy, cystocystanostomy, ventricular cystostomy, more or less ETV. If you can do ETV, it's better because additional ETV significantly improve the results. And of course, the association of these treatments. What do you think is the best? Overall quality of life is comparable between patients undergoing open surgery for 6 excision or fenestration or endoscopic treatment and cystoperitoneal shunting over 5 years. So it's the same 5 years later. And it's a very important paper with more than 1,000 cases. Sylvian fissure arachnoid cyst, their management remains controversial, mainly because there is the problem of neurodevelopmental outcome. Some authors think it is similar to the control group, the group without surgery, but there is a subgroup that does have an increased risk of poor outcome. Some are more categoric and state that there is very limited role for surgery in improving the intellectual ability. Anyway, the neurodevelopmental assessment must be part of evaluation. It's very, very important. And in our experience, as and the team from NECA has the same experience, we moved from endoscopy to open microsurgery with very limited incision. Here, in this case, I think it would be a good idea not to use an endoscopic techniques because, as you can see on this coronal view, the third ventricle is very narrow, and it's very unlikely that you can navigate in this cyst and find the way to go to the third ventricle. So we think it's better to go for cystoperitoneal shunting. In case of rupture, subdural effusion, we usually use umbrella catheter without valve. And sometimes, if symptoms are not so important, you can start with conservative treatment, bed rest. Suprasellar arachnoid cyst treatment. Endoscopy is our favorite in this situation, so that's before surgery and after surgery, and you can see the flow between the cyst and the ventricle and the flow at the site of the ETV that was done on the same procedure. Here, Galaxy 3 cyst, we have mentioned it before, that's December 2013, and that's the situation on May 2015 after cystoperitoneal shunting without valve. We can discuss to put an additional valve, why not? But I usually do it without a valve. And if you go to cyst marsupialization, that's what we do for Galaxy 2 arachnoid cyst. So the goal is to make as much holes as you can to the basal systems. In conclusion, most arachnoid cysts in children are asymptomatic and remain silent. They do not require any treatment, whether or not the diagnosis was made on pre or postnatal period. The vast majority, without brain abnormalities, does not increase or sometimes decrease in size and, of course, remain symptomatic. They are compatible with a normal life, with or without requiring surgical treatment. The treatment options are microsurgery, cystoperitoneal shunting or endoscopic techniques, and overall survival, overall quality of life at 5 years, is the same, whatever the technique you use. The Sylvian fissure arachnoid cyst is an acquired condition, so they must be followed by serial MRI and to a clinical point of view, interpreting headaches is probably one of the most important issues before surgery. Epilepsy is contingent, and the prognosis depends on the brain malformation. So just 2 slides from my town, Nancy. Here is the City Hall and Stanislas Square. And thank you very much for having paid attention.
Thank you very much, Professor Olivier Klein, for this amazing talk. And I'm sure that we will have many questions by the end of the 3 talks during the discussion session. Well, now we can move to the second speaker, Professor Issam Shail, and I will ask Dr. Mustafa Hamama to introduce Professor Issam Shail. So before Dr. Hamama is Assistant Professor of Neurosurgery at the First Department of Neurosurgery in Morocco at Ibn Sina Hospital, and he is Assistant Treasurer of the Moroccan Society of Neurosurgery. Please, my dear friend, will you introduce Professor Issam Shail, the President of the Arab Pediatric Neurosurgical Society? Thank you.
Thank you, my friend, Dr. Darqawi, and thank you, Professor Abadi, and thank you, the Moroccan Neurosurgery Society, for organizing this webinar. Dear colleagues, please let me introduce Dr. Issam Abdulaziz Al-Shail. Dr. Issam is the Director of International Affairs of King Faisal Specialist Hospital and Research Center. He's obtained his MBBS degree from King Saud University in 1988 and his fellowship in neurological surgery for King Faisal University in 1995. He further specialized in the field of pediatric neurosurgery at the Hospital of Sick Children in Toronto. In 2008, he obtained his MBE in healthcare management at the Faisal University with honors. Over the years of the practice and experience, Dr. Issam became an expert in the field of microsurgery, pediatric neurosurgery, neuroendoscopy, and craniofacial surgery. He introduced pediatric neurosurgery as a subspecialty, spread out the GCC country and training lab for microvascular surgery. Presently, he is a professor in the College of Medicine at Al Faisal University. Dr. Issam is also involved in a research study, and he is a scientist in the Research Center of King Faisal Specialist Hospital. Please, doctor, go ahead.
Professor Assam, will you turn on your mic, please? Thank you.
Apologize. Thank you very much, Dr. Hammam, for this introduction, and thank you, Professor Badi. Thank you, Fahad, and really, I'm delighted and honored to be part of a very prestigious and homogeneous group, the Moroccan Neurosurgical Society. And actually, if you allow me, I can start sharing my presentation. Actually, I chose this topic because it's actually neurosurgical / public health issue. And I wanted to share our experience in Saudi Arabia, since we, between Saudi Arabia and Morocco, as a when it comes to the community, when it comes to the people, we're close culturally to a great degree. And so maybe with some of the ideas that can help over there from the things that we managed to achieve in Saudi, if anybody interested to pursue. My title is going to talk about myelomeningocele from prevention to improvement outcome. And okay. Well, just briefly, a brief introduction about spina bifida. It's one of the most common compatible with life congenital anomaly that we encounter in neurosurgery. And it causes a quite significant congenital impairment and malformation. And it happens actually, this malformation happens very early on in the pregnancy, when at a time when the mother doesn't know if she's pregnant or not. Now, of course, briefly, the classification of spina bifida, now it is called anatomical and neurological leaf. Just to remind everybody, the anatomical is spina bifida aperta and spina bifida occulta, myelomeningocele and lipomyelomeningocele are examples. And however, the embryological classification is divided into primary neurulation error, which is a very early defect that happens during the early formation of the central nervous system. And the end result is myelomeningocele, plus other deformities that many of them are not compatible with life. The secondary neurulation, where it happens a little later in the development, and here we'll have a coverage, and there will be some deficit, but not comparable to the myelomeningocele. Example to that is lipomyelomeningocele is another example. Now, spina bifida, since it's a very serious birth defect, it is associated with a lifelong disability with a varying degrees. And it's about 3,000 pregnancies are affected with the neural tube defect in US, and 300,000 worldwide. Now, the lifetime direct cost of care for one child born with a spina bifida in US is about nearly $800,000 US. Now, if you remove the cost of caregiver, it will come down to nearly 600,000. And that is excluding the equipment and all the supplies that is needed by the patient. So there is in addition to this financial devastation, there is a great social and emotional cost for those children and their family. Now, what causes a neural tube defect? Of course, we have genetic and environmental. And, it's about, when it comes to worldwide, it is about 0.5 to 2 per 1,000 pregnancy is affected. So it's when you go worldwide, it's a quite significant amount of disabled children. Now, regarding the inheritance, it's a multifactorial inheritance, and it has been identified. Some of them might be identified with gene abnormality, gene called brachyury, which is directly related with a neural tube defect in a human. And we have reported actually a family that carried that gene, and 4 members of their children are affected with the neural tube defect. Some of them were devastated. Environmental risk factors, there are many of them related to past history of having a child with a neural tube defect, taking anti-epileptic medication, diabetes, inadequate folic acid intake, pregnancy, obesity, living in a hot climate. And that was some of the literature. Here is a paper from Saudi Arabia that came up, written by Professor Mustafa Saleh. He's from Sudan. And they talk about some risk factors involved in neural tube defect. And it's a concurrent case control study. He collected 25 affected patients, and the control were 125. And he identified only past history of stillbirth has significance in some of the cases. Family history of hydrocephalus also played a fact. And no doubt he confirmed the protective effect of folic acid. The rest of the environmental factors were not that significant, but I think this is related to the size of the sample. Now, in US, of course, in 1992, fortification started by US Food and Drug Administration. And that has actually resulted in a quite significant reduction in affected children, nearly 1/3, with estimated savings of nearly $1 billion annually. Now, this is some of the table that was some of the tables that were included. Now, when it comes to preventable neural tube defect, now with the presence of folic acid, we have quite significant reduction of those cases. But unfortunately, only 25% of the needed cases to be prevented is being prevented. The rest are not really prevented by folic acid. And this is probably related to economical, environmental, society, etc. reasons, other reasons than actually medical. Now, in Saudi Arabia, we started about 20 years ago, and we wanted to collect enough data to look into this issue, and maybe we can manage to go nationwide to collect data, to to help the Ministry of Health to take the right decision toward this disease. And we have established a data neural tube defect registry, hospital-based, and eventually this turned to be a national national neural tube defect registry under the umbrella of National Birth Defect Registry, hosted by the National Health Council. Now, what is the difference between registry and research database? Eventually, I'm going to give an answer for that question. Now, a registry is a surveillance tool. It monitors long-range trends of the disease. It provides sufficient data for hospital administration, and it is spin-off. It allows spinning off some research project. Now, the registries can be hospital-based or population-based, with something that we can. Now, why it is important? The importance of registry: it provides important source of data, enabling healthcare worker to estimate the magnitude of the problem and to assess the result of therapeutic effort. Now, this is the story that I mentioned earlier, that we started in 2000, year 2000, establishing a hospital-based registry, and eventually the story is that, you know, people in our society, they don't rely on actually written information. They rely on their memories, which is really difficult to, it's going to be inaccurate if we start recalling those information to be entered into the registry. And that was the main challenge initially. And that's why we took us about 2 years to develop the registry data forms. We had put a strict criteria in designing the questionnaires, and those criteria is though have to be simple and clear. The question has to be simple and clear. The answer had to be simple and straightforward. Most of our questions answers were yes or no. So this is something that helped us to collect actually reliable data to a great deal. Although the number of the variables have reduced greatly, but it's a registry, and in a registry, you really don't rely on a large number of variables. This is where the spin-off study come in place. And that's why registry is different than research databases, because registry cannot tolerate missing data, but registry database can tolerate some of it. And we did it because we had a fantastic registrar who ensured the validity and reviewed the literature, communicated with families, documented all the data. And this is the publication of our national data when we converted, just before converting it into the national registry. Now, briefly, we had about 718 patients we registered. Mostly were female, and 24 of them were attending school. 30% of them were handicapped, and 12% were still infant and did not reach the walking age. Here, that's the problem, as most of the mothers did not have antenatal ultrasound early enough. Most of them, some of them had it during the 3rd trimester, but most of them had it at the time of giving birth. And that's why we cannot figure out, we cannot catch those cases early enough. Now, most of the spina bifida had myelomeningocele, and 60%, nearly 60% had hydrocephalus. And among those the hydrocephalus was diagnosed antenatally. Now, majority of cases underwent repair after birth with a VP shunt after the repair is done, not simultaneously. Few had it before. And 95% of the mothers did not have folic acid. And 72% had the folic acid after they were pregnant. Now, and this is some of the, that shows the parental history, that shows genetics and being relative increasing relation within the family is not really part of, is not associated with causing spina bifida. And of course, nowadays, of course, with the improvement in our neurosurgical care, we have reached now to antenatal repair of myelomeningocele. And in US, it showed that the survivors of spina bifida they were 20% in 1950 compared to about 80% in 85. Now, the concept of spinal cord injury, this is a very important concept, and I really, and that's what triggered actually many people to think about considering antenatal repair. That was from the early 80s. And in utero, spinal cord, first of all, we have got the failure of neural tube formation. Second is the exposure to uterine fluids and mechanical effect from the uterine wall. Of course, this exposure will lead to eventually to a progressive damage of this placode. With this, also to motivate formation of herniation of the hindbrain structure. Now, this is a chemical and or mechanical insult theory, and you can read it there. I have included a few references here. And it states that the chemical and or mechanical insult to unprotected fetal spinal cord will lead to be exposed to amniotic fluid and uterine wall are involved to progressive in utero damage. So the damage of the spinal cord among those patients happen in utero as well as after delivery. Of course, it can be during the birth, giving birth as a mechanical injury. In case the family decide to go to C-section, then there is a chance of trauma, dryness, infection, ischemic insult that can happen before or during the repair, retethering, syringomyelia. These are really late trauma. Now, when it comes to the traditional repair of the myelomeningocele, I do have a list of do's and don'ts for myself, but I can read them over to you for anybody who's interested. You know, I always have a plastician with me doing these cases. Dura has to be handled carefully. You have to be very gentle in dissecting the dura. No sharp instrument should be used to hold the dura, like tooth forceps. They create puncture holes that eventually will leak CSF. We close the dura, all the dura tears and openings. I will close the placode, and if you can see that the placode here, it's a flat, so you can just fold it and put a few relaxed suture, continuous suturing to help reduce this raw surface against the dural closure. And we always check a water jet test with the last stitch of the dura to make sure that there is no obvious big hole that is leaking a lot of fluid. Now, this is just a case that I have done. You can see this is a huge defect. And this is a dura. The dura, you can see that with arachnoid cyst, and this is a placode. Here, where the placode is identified and dissected nicely and cleared, because there is also a thin layer here of junk tissue that is protecting the placode. But again, some of them, they can be cleared. And you can see, if you can proceed, follow that, we can reflect the dura circumferentially. And you can see here, I have sutured the placode after it has been identified. I have sutured it, and I'm starting circumferentially to open the dura and reflecting the dura very carefully, and then closing the dura watertight. This is another patient, but this one came really late, where you can see some of the granulation tissue that is gathered at the repair site, but unfortunately it did not close the defect. So we had to go back, and you can see that we had to go carefully and remove all this junk tissue. And you can see that this is the spinal cord here, and you can see the placode is nicely clearly displayed. And this placode was closed, and the dura was reflected, and we closed the defect. This is schizencephaly more than actually a simple, because you can see that it's very wide dural vertebral defect. And you can see I had the plastician to do me these flaps, which have, both of them have healed eventually. But you can see how difficult it is with the lateral release on both sides. Now, a few words about prenatal surgical repair, mounting clinical, and there is a mounting clinical and experimental evidence showing a neurological deterioration and progressive damage to the open spinal cord during gestation, provided the rationale for exploring the prenatal surgical repair strategies. And you see some of the references, they go back as far as 1990s. Now, a multi-center randomized prospective trial compared the outcome of in utero fusion repair with a postnatal surgical repair defect was in favor of prenatal because it reduced the number of children with hindbrain herniation, decreased the need for cerebral spinal fluid shunting, and increased the ability to walk independently at 30 weeks of gestation. Now, what happened in Saudi Arabia? We do have an antenatal or prenatal surgery program, but the problem is we could not catch diagnosis of a pregnant woman with a child that is having a spina bifida early enough to perform the surgery. And that's why most of the antenatal or prenatal surgery program that we have is doing only airway surgeries and some of the pediatric surgery cases. We're still looking for one, but until now we haven't encountered one. Now, as a final word, while in utero open surgical MMC repair is neither a cure nor free of risk, prenatal repair is more effective than postnatal repair and is now a treatment option for patients who meet inclusion criteria. And with that, I thank you all for your time and listening to me.
Thank you, Professor Hassan, for your...
Thank you. It's really a tremendous work that you have done in Arabia Saudi, especially in this field. It's really we will show us a great work. Thank you so much, and congratulations for this.
Thank you.
So may I ask Professor Al-Khdar? Good evening, Professor Al-Khdar. Will you please introduce, Professor Al-Khdar is the president of Moroccan Society of Neurosurgery, and please introduce Professor Souad Bakhti, the president of the Algerian Society of Neurosurgery. Thank you.
Thank you. Thank you, Professor Bakhti, for your participation to our webinar. Professor Souad Bakhti is currently professor of neurosurgery at Medical School of Algeria, of University of Algiers, and she is the head of Department of Neurosurgery in the University Hospital Center Ari Tidir in Algiers. She is the past president of the Mediterranean Association of Neurosurgery, and currently she is the president of the Algerian Society of Neurosurgery, chairman of the Wing WFNS committee, and she is the founding member of the Algerian Pediatric Neuro-Oncology Group and the vice president of the Continental African Association of Neurosurgery. She is involved mainly in pediatric neurosurgery, pediatric neuro-oncology, orbital lesion, and chronic subdural hematoma. She is involved in the training of African young neurosurgeon in the program of 100 for Africa. So thank you again, Professor Souad Bakhti will give a talk about orbital lesion, a peculiar topic in pediatric population, orbital lesion, the management of orbital lesion in pediatric neurosurgery. Thank you.
Thank you, Professor Lakhdar, for this nice introduction. And I will... And first of all, I want to say thank you to the Moroccan Society and to Professor Najia Al-Abedi for the invitation, and it's a great honor and pleasure to be with you, and also to congratulate the Moroccan Society and particularly also Najia Al-Abedi for this nice series of webinars that are organized all Thursdays. So today I will talk about, of course, disease which is not so frequent in children, but we sometimes can be faced with these patients. And I just want also to say that orbital lesions, the management of pediatric orbital lesions is a part of neurosurgery, since we are dealing with the orbit, which is in relationship with the skull base. And so we have to learn this kind of surgery. As I said, it's uncommon in children, and unfortunately, it can be sight-threatening and even life-threatening, depending on the histology. Of course, histology is very different from adults, and unfortunately, the rhabdomyosarcoma is the most common tumor in this category. Also, what is very frequent is the vasculogenic lesions, which are common in newborns and young children. And what is important to say is that imaging now can allow to make the difference between several tumors, and then we can approach a good diagnosis. Surgery is the cornerstone of the treatment, but sometimes this surgery can be very challenging, and particularly when it is when we are thinking about reconstruction. So this is what you have to do if you want to have a good care. Of course, a good knowledge of anatomy, adequate imaging, and what is very important is the thorough preparation and the precise planning. And also, you have to be with a multidisciplinary team. For the anatomy, I will not detail because we don't have time, but this nice paper and other papers talk about this famous rule of 7. 7 bones, 7 muscles, 7 nerves. And if you know that very well, you can find the corridors for surgery and you can avoid a lot of complications. So just this slide to see the bones that are involved in the orbit, which is a pyramid, as you can see, and the relationship between the anterior cranial fossa and the middle cranial fossa, with all the vessels of the and the nerves that you are seeing here. Clinical examination, of course, the first sign, the most frequent sign is proptosis. This proptosis can be very important and sometimes very slight. And also the evolution, you can have proptosis that will go very, very fast and sometimes very, very slowly on years. And other signs, of course, but which is very important is the decrease of visual acuity. And unfortunately, a lot of patients will come with blindness. This means that the tumor is compressing the optic nerve, and very often that the diagnosis was delayed. These are some examples of proptosis that we have in our patients, and you can see this very slight, this moderate, and this monstrous proptosis. Some of you will say that these are historical cases, but no. Sometimes when the proptosis is going very fast, and sometimes patients are very far from centers who are dealing with these lesions, so you can have this kind of proptosis. Imaging, of course, MRI is very important for the location, to study also the invasion of adjacent structures, and also to choose your surgical approach. CT scan In many instances, we have coupled CT scan to MRI because we think it's better for the bony structures, in particular when we are thinking about reconstruction. Ultrasound, maybe we have many patients who are coming from ophthalmology with ultrasound, but we can't imagine a surgery with only with this exam. With this imaging, we can have a topographic classification, which is very important with this extracorneal and intracorneal and this different location of the tumor, because it's the only way that you can choose the right approach to these different lesions. These are some examples, imaging of our patient. You can see here an MRI with this lesion, which is on the lateral wall with a distraction. It was a rhabdomyosarcoma. This lesion inferior, lateral and inferior, and with the displacement of this, the ocular globe, and this lesion in the CT scan, which is superiorly located with this huge displacement of the globe. This is an MRI of an optic nerve glioma, and this is another. And you know that this entity is very particular, and very often seen in the field of neurofibromatosis type 1. And this lesion have to be discussed closely with the oncologist, since surgery is not indicated unless the patients will develop a big proptosis with inflammatory signs. Also a particular entity, the plexiform neurofibroma, and you can see that generally it arises from peripheral nerves, and particularly the sensory nerves, but sometimes they can have this course and entering intracranially by enlarging this the superior orbital fissure, and you can see this nice CT scan in 3D reconstruction. For the surgical techniques, several techniques, conventional surgery with many approaches, transcutaneous, transconjunctival, medial, lateral, transcranial. Of course, exenteration is a technique that we have to use in some instances. Endoscopy also is developing more and more, and the choice, of course, as I said, depends on location, but also on surgeon's experience. When preserving function, of course, we have to preserve function whenever it's possible, but also it depends of the lesion, the lesion, and also of the expected quality of life. And if we are faced to aggressive lesions with a poor quality of life, efforts can't be justified. For the transcranial approach, mainly for the apical lesions, we use a fronto-orbital monoblock bone flap, and the size is very variable. It depends on the lesion, the extension intracranially or not. We emphasize about the maximal preservation of the orbital roof, and of course, the fronto-lacrimonasal pedicle, because it can produce some complications as palsy of the front. Also, we emphasize about the reconstitution of the peri-orbita perius. Personally, I do always reconstruction of the orbital roof, and many people ask me why. I'm not afraid about enophthalmia because I didn't see it and it is not reported in literature, but I think it's really a personal preference, and it's not so difficult to practice. So why not? This is a kind of fronto-orbital monoblock, and you can see that we have preserved the maximal part of the orbital roof. This is another fronto-orbital monoblock which is very large, because you will see the case after. It was an orbital encephalocell, and we need all this exposure. This is also how we preserve the frontolacrimonasal pedicle, and sometimes in very young babies we are obliged to drill to liberate this structure. For the reconstitution of periorbita periods, of course, it is not always possible, because sometimes invaded by the tumor, it is distracted, but when it is like this, so we preserve it, and we can suture it after, because we are always afraid that orbital structures can be entrapped in the bone flap and maybe cause some complications in the future. For the latter approach, mainly for mid-external lesions, and sometimes for superior compartment. In our experience, and it is also described in the literature, we don't have to remove, not resection, I'm sorry, there is a mistake, to remove the lateral rim. We just resect the lateral wall of the orbit and can work in this corridor. This is an example of our patient with a lateral approach, this young baby with this proptosis. You have the imaging here. It was a meningocell, the baby in postoperative period, and you can see the MRI, the control MRI. Another example, this girl with this lesion. Of course, there was an inferior part, but we were sure that it was a rhabdomyosarcoma by imaging. So we performed, and we could achieve a very good resection. And this is the girl 2 years after treatment, and she is currently at 6 years alive and going to school, and everything is okay with her. For the inferior approach, mainly for, of course, lesions inferiorly located, and this is an example, and you can see the incision. And also we perform, very rarely, but we perform an inferior transconjunctival approach. You can see this huge mass under the eyelid, and this is the conjunctiva and the tumor and the child after resection of the tumor. Exenteration, of course, I'm always not comfortable when we have to do an exenteration, but unfortunately we have to do it in some instances. So this is, you can see this globe, and this is perioperatively, and this is the part that has been resected, the globe with the tumor. We do that mainly when we have refractory tumors and when the group of oncology asked us for this. We have a small series of children with 35 pediatric cases among a total of 115 cases of orbital lesions, which means that children represent 1/3 of our patients. The age range from 2 months to 50 years, but I have to say that in our department, the particularity is that we have a lot of children under 2 years. I have to precise that many departments of neurosurgery in Algeria deal with orbital lesions in children, but I think that we have cases younger than other departments. These are the techniques that we use in our department, and we don't have any experience in endoscopy. The complications of the series, unfortunately, we've had 1 death in post-operative period, and I will show the case. It was a girl who come with very, very poor conditions and a huge tumor. We have had a permanent ptosis. It was in the first experience, and maybe I'm sure it was a problem of dissection of the muscles. We've had also regressive ptosis, chemosis, and other complications that are described in literature are diplopia, and usually it happens when we don't reconstruct the floor of the orbit, and it is a consequence of malposition of the orbit. Epiphoria also is a problem and can result in dysfunction of lacrimal duct, and telecanthus, of course, when we make a transection of the canthal ligament. Here is the histology of the lesion that we have, and it confirms the result of literature, which in the tumor we have the rhabdomyosarcoma in the first line, and after we have dermoid cysts. You can see that we have only 2 lymphangioma because we operate a lymphangioma only when they are when they cause very important proptosis with inflammatory signs and other lesions that are also described in the literature. This is a case of a boy of 5 years. He was seen in another town, and he go to ophthalmology with this tumor, and they performed a biopsy, but unfortunately it was inconclusive, and we received the child 2 months after, and you can see this proptosis with this chemosis. So we have operated the patient, and we have achieved a gross total resection, and it was a fibrous solitary tumor. Unfortunately, before the surgery, the ocular motility was impaired in this child. And I have to say that we have to operate him 2 times after the first surgery. He made 2 recurrences. Currently, the last surgery was 2 years ago, and he is doing well. No progression, no recurrence. This is another child of 8 years, and you can see this bone lesion. And so we have operated him. Here's the tumor. This part was resected with also the part of the orbital roof. And we have done a reconstruction with autograph. And you can see that I don't have plates. I use iliac crest in this child and just sutures. And of course, this is interesting because everybody has not the same financial resources. I know that people are using plates, but in developing countries, it is not always possible. And you can see the result 6 months after. This child has been operated 4 years ago, and he is doing very, very well. This is also a case of a very young baby who came with this displacement and proptosis. And it was, you can see the CT scan in 3D reconstruction. It was a cephalocell which is particular to bone defect. But the lesion was here in the orbit, and you can see that on the CT scan. We have operated her, and this is the result at 2 years. For us, we are not totally satisfied by this cosmetic result because the hypertelorism, but parents are very satisfied. This is also a young baby of 4 months with this huge chemosis and proptosis. And you can see the image with tisular and cystic lesion, perioperative. There was in the cyst a liquid that was resembling to CSF, and analyzed confirmed that it was CSF. and the histology concluded to a glial heterotopia with glial cells and also cells of plexus choroid. And this is the child after surgery. She underwent after a graft of cornea. And this case was published in Child's Nervous System. The rhabdomyosarcoma, just one word to say, because it's the most frequent tumor in children, to say that the age range from 6 to 8 years, but in our series, the patient on 11 patients, 5 was under 4 years. And you can see what are the syndrome that where is the risk very increasing. 2 types of histology, and theoretically, when you have an embryonal type, you are located in supermedial quadrant, and alveolar are in the inferior part, but this is not always verified. And we can have also metastasis and local lymph node. What is important to say is that generally the survival rate at 10 years is about 80%, and recurrence can occur in 17% in the before 18 months. But I must say that in our series, we don't have till now survival at 10 years, but we've had a lot of patients who died in spite radiotherapy, chemotherapy, and maybe we think that because our patients were very young. This is a young girl who come with this, we operate her. This is during the treatment, and this is after the treatment, and she will have a replacement of the globe and surgery of the eyelid. This is another boy with rhabdomyosarcoma, and he's this photo at 5 years, and he's currently alive, going to school and have a quite normal life. We have some problematic cases as lymphangioma, but it is the case in all literature. What should we do? Should we operate them when we have this kind of proptosis? But, and you can see here some abnormal vessels, but when you operate these patients, you are sure that you will not achieve a gross total resection. You are sure that you will have only a partial resection. And after that, you will have recurrences and regrowth. So what should we do? Sclerotic agents are sometimes discussed, but results are not conclusive. And for cryotherapy, maybe. I don't have any experience. I've talked with my friend Matula from Vienna, and he said that we can achieve better result with this. This is the girl who died in the postoperative period. She came with this proptosis, with a history of 2 months of proptosis, and you can see that the tumor was continuing intracranially. So we have used an approach in the orbit and also intracranially. We have removed the maximum of tumor, but the girl was very, very poor condition with hypoprotidemia and died 10 days after surgery. And it was at the histology an undifferentiated round cell tumor. A recurrence of rhabdomyosarcoma. This girl was operated in another department for a rhabdomyosarcoma of the lateral rectus in 2014, followed by chemotherapy and radiotherapy. And you can see the images. And she had a recurrence in September 2050. We do a surgery with chemotherapy, and we perform in a PET scan who said there is no tumor with this image. So we were obliged to trust in this exam. But when we see the evolution in June, it was a huge tumor. And was it a false negative? I don't know, maybe. We have operated again the girl with a very, very good resection, but unfortunately, she died 6 months after. This is also a boy who were operated 4 times with radiotherapy, several shame of chemotherapy, and you can see the huge tumor and the invasion of fascial, and this was the boy with this tumor, and he died, of course, 1 month after that. Untitled cysts, no many literature concerning that, but we have a total of 4 untitled cysts in all the series, and 2 among them were in children. All of them were perioperatively broken because capsula was very adherent to adjacent structure. So they were ruptured, and of course they recur. One of them recur after surgery. Of course, we can think about medical treatment as albendazole, but we have to know that it is not always so efficacious as in spinal hydatidosis. This is also a boy who were living very far in the extreme south of Algeria. He come with this huge lesion, and at surgery, unfortunately, it was a mater teratoma. So we have, of course, made an exenteration. And what about the reconstruction, which will be very, very complicated in this boy? So in conclusion, early diagnosis is very important because you can avoid blindness, and you can avoid the kind of lesion that I show. Orbital lesions in general are sometimes very challenging. And what is important is that we have a wide variety of lesions. And so you have to have a very good pathologist with you. Of course, the multidisciplinary team is very important. And for the craniofacial team for reconstruction also. Unfortunately, I couldn't create with my colleagues a team for this kind of reconstruction, and it is done case by case, not always communication. And what we are doing also is to develop endoscopy in our department for orbital lesion, at least the inferior and the medial lesion. And I want to thank my colleagues who are dealing with orbital lesion, with Dr. Nabila Tirilt, who many of you know. She is surgeon with me, Professor Fatiha Gaji, who is a pediatric oncologist, Professor Fella Terkmani, who is our pathologist, and Dr. Shrifa Louni, also pediatric oncologist. And I want to thank you for your attention.
Okay, thank you, Suad, for this excellent presentation and amazing cases. And it's the proof that unfortunately, as you said, in our countries, we continue to see this this type of lesion lately. I hope in the future we'll see less than this image. It's very it's really it's a threat, like when you see some case that you show us this evening. Maybe Fahd, you continue the discussion with the panelists. Questions for the 3 speakers, and maybe some comments from the panelists. Professor Kizito, Professor Ashori is here. He joined us or not yet?
Mr. Ashori was trying to join us. He has problem with connection, but he will join us soon. Professor Kizito and Professor Hamama. Maybe Professor Kizito has a question for Professor Issam Shail. Dr. Kizito.
Please, I ask a question for
Yes,
Professor Olivier Klein. Thank you for your very interesting talk about the arachnoid cyst. My question is about the MRI, mainly the flow of CSF, the pre-operative flow study of CSF at MRI. Is it useful to manage this cyst and to decide what to operate or not first? And what are the criteria for shunts and for other procedures? Is it useful? And for sometimes, mainly in posterior fossa, we may have, for example, other types of cysts like Untitled Cyst. I know it's not very useful to know it preoperatively, but is it in? Are they any specific sequences to distinguish other types of cysts from arachnoid cysts? Thank you. The mic, please. Could you please activate your mic?
Okay, you hear me?
Yes.
Yes, thank you very much. So
Yes.
the choice between cysto-peritoneal shunting and direct approach, mainly microsurgical approach, depends on our experience of the size of the cyst and of the age of the child. For example, if the cyst is too large and you use endoscopic technique, you will have a result sometimes months or years after that, after the operation on the cyst size. So for Galaxy 3, we use shunt. For Galaxy 2, most of the time endoscopy. About the radiological sequences, I think it's very, very important to have CIS sequences, CISS, to check whether or not there is a membrane. So is it a cyst or not? And to have a clear localization of the membrane. And sometimes the sequence is called HAST, H-A-S-T-E. So it's quite the same, and they are very, very useful. First, to demonstrate that there is a cyst, to see where the membranes are, and to plan your surgery.
Thank you, Professor.
There is a question on for Professor Shail. It's about the myelomeningocele when it's associated with the hydrocephalus. When did you operate myelomeningocele first, and how many time after you did the shunt or shunt before? This is a question from the chat. I just saw it. For Professor Shail.
Thank you very much, Professor Al-Badi. About the shunt, not all the hydrocephalic, so myelomeningocele or a neural tube defect, they will require shunt. Only 60% of them. Therefore, we always delay the shunt after the repair. Second, closing the defect early enough at least will reduce the chance of infection and allow the patient to grow a little bit so that he can acquire some immunity to resist shunt infection to some degree if there is any chance. Putting a shunt early on with an open defect, there is a great potential of shunt infection, and the consequences of infected shunt in children with myelomeningocele is devastating. I mean, they lost their chance to survive decent life. That's why avoiding it is much better. Avoiding the shunt infection is the best thing we can do for for those patients. And the most important, if you can manage to close the defect and ensure that there is no CSF leak, Then once the patient starts growing his head circumference or his ventricles, then that's the time when we put the shunt in. Did I answer the question?
Thank you.
Professor
Yes, I
Hamdishi has a question.
Please.
when we can avoid to put shunt, it's sure it's the best way. But as you said, in 60% you have hydrocephalus. And sometimes, if you not do the hydrocephalus before and repair the myelomeningocele first, you have sometimes the fistula. Even if you repair the perfectly, you can have some fistula in the location of myelomeningocele. And 60%, you are no choice to you should to put a shunt. And of course, we cannot use the endoscopy in our experience. I don't know what about your experience and the endoscopy and the hydrocephalus in this young baby.
Yeah, I know the Paris experience endoscopy for spinal myelomeningocele patient is they support this, but I really don't. I would put a shunt for all of them if they need it. If the hydrocephalus is active, then I would put a shunt or not go for endoscopy. The reason is it's a hindbrain abnormality that will not allow the third ventriculostomy to work the way it's supposed to work. Second, there is a risk that because the structures are cramped in that region, so there is a risk that it might lead to a serious complication. I wouldn't take that route. I would just go for a shunt. Simple, straightforward shunt. Now, a dural closure I know is a challenge. That's why I gave the list of do's and don'ts that I always remind myself when I'm doing one of those cases. Yes, but can we get a really watertight seal dura? Yes. And you can, the last stitch you can do the water jet test where you can just get a cannula and you can inject the normal saline in the dura with a tight before you tie the last stitch. And you can see if there is leakage coming from here and there. Then you can put a stitch here and put a stitch there. And eventually you can see that there is no fluid leaking around. And those cases, they actually, among the cases that I have done, they will start growing their head circumference before they collect CSF at the repair site.
Thank you.
Fad, may I say a
Professor
word,
Hamdishi, Fad?
please?
Yes, Professor.
Yes,
Yeah.
Professor.
Do you hear me?
Yes, we
Yeah.
hear you.
Yeah.
Yes.
Good afternoon. Good afternoon,
Professor.
everybody. Congratulations, Najia, for this nice webinar.
Thank you.
And for also all the young colleagues who are helping you to organize these webinars. And thank you for our excellent speakers. I have one question for each one of them, if you allow me. First, Dr. Klein, I think you have given us an excellent overview about this not easy arachnoid cyst to be dealt with. And you mentioned that you emphasized that the most important problem is to establish the relation between the symptom and the cyst, and of course, to decide the treatment. And as you know, and also mentioned, there are two main symptoms, the headache and epilepsy, who are not easy to relate to the pathology, especially if the epilepsy is well stabilized by the anti-epileptic drugs. So what is in your practice and what is your advice to our young colleagues and to all of us to make this, to be sure of this relation and to establish it, and then to decide to go for surgery or for any other treatment technique. My dear Dr. Isam, it's first great pleasure to see you. And you have also given us an excellent talk about this difficult problem of neuromeningocele. Something really interested a lot me in your presentation is this register you have created some years ago. I think it's very, very important, and I hope that many other colleagues in other Arab countries and through maybe the umbrella of the Pan-Arab Neurosurgical Society, you can maybe try to work in that with the administrative council of the society to establish such registers. But my question is, I have seen that your register is located in your hospital. You have created it. So is it just limited to the patients you see in your hospitals? Of course, maybe many of them are forwarded to your hospital, but or you have some connection with other hospitals, and you try to make from it a kind of national register. Now, my dear Suad, as usual, your talk are also outstanding, and thank you very much for this presentation. But you have shown us two things: this very severe prognosis of rhabdomyosarcoma, and one very nice case at 5 years follow-up in very good shape, very, very good evolution. Can you tell us some differences in this severe tumor, which makes this difference between the group of cases you have shown us, very severe, and this one?
Okay,
so these are my questions. If each,
First, thank you, Professor Hamdishi. I think Professor Klein, he will answer first, and then, of course, Professor Isam and Saad.
Yes, thank you very much, Professor El-Kamishi, for this question. We are here at the real center of arachnoid cyst, so the relation with headache. It is easier for the relation with epilepsy, as there are really no evidence epilepsy and arachnoid cyst. But headache, these children complain frequently from headache, at least half of them. And the problem is there, headache without intracranial hypertension. At these times, in this situation, there is no evidence-based medicine to go immediately for surgery and be sure that headaches will be ameliorated later on. So I am very, very cautious. And in cases where there are only headaches, I advise a specialized clinic. We have headaches clinic for adults and for children. And with the most of the time it's a neurologist, sometimes with a psychologist, and to make an idea of these headaches, tension headaches. Is there any problem of anxiety? Is there any other problems? But headaches without any other signs of ICP, I'm very, very cautious, and I'm very reluctant to go to surgery, at least at the beginning of this follow-up.
Thank you.
Thank you, Olivier. Professor Shail,
Yes,
have you an answer for Professor?
Professor Khamdishi, it's
very important. Is it a policy of health system in your country, or is it only in your hospital? This initiative, it's only in your hospital?
Yeah, see, the things that I was just saying, long time, Professor Khamdishi, very nice to have seen you, and thank you for your statement. About the process, it started actually in our hospital, and we have developed a research, the registry data form, which was very difficult actually to verify and make it robust and user-friendly and reliable form. This is the registry is a form. If you have the form, you can use it anywhere. The only thing you need to have people encountering, recognizing the families and approaching them. Now, after we have developed the form and we used it for about 10 years, I think, we collected about 715 cases or 14 cases in our center. Then I took it up a little bit, and we did establish a national, a pilot study for a national registry. And I took it through Saudi Health Council, which is actually the health authority above Ministry of Health and other healthcare providers in Saudi Arabia. And we piloted in about 8 hospitals where we have identified and trained registrars in each center. And we set up a process by which those registrars will be able to encounter, recognize those patients, and interview the family and keep a contact with the family for later on follow-ups if there is any information that's missing. And it was really successful. And then now it is actually a national registry. It involves all the sectors of Saudi Arabia, and it is under the umbrella of the Saudi Health Council, being part of the National Birth Defect Registry, which is a huge registry. Mind you, that includes even the metabolic diseases. We do have a lot of them. So actually, now when it comes to sharing this experience, that's why I'm presenting such experience in this prestigious venue, something that we can share, we can talk about, we can discuss, we can exchange some expertise. And you don't need to start nationwide. You can start in your in a hospital, and then you start building the expertise, the support, the financial support that you need also to hire an individual that will, the equipment needed, the computer system, etc. So I think, and that's why it took me about 20 years to reach this stage.
Maybe our panelists.
Thank you, Professor. The proposition of Professor Khamdishi is to start maybe a trial between the Arab country and on the umbrella of the Pan-Arab Society, and you are the president of the Pediatric Pan-Arab Society. Maybe we can together establish something that maybe not a register, but a study concerning all the Arab countries first. Thank you.
Absolutely. Why not?
Thank you. You have the mic.
I think I have to answer Professor Khamdishi.
Yes.
Thank you, Professor Khamdishi, for your kind words. For rhabdomyosarcoma, I think I forget to say during my presentation that we have made the remark that our baby, the children was younger than those described in a lot of series. But we think in our group that the main problem is with molecular biology. Even if we have the same, we have, I think in the series we have only two alveolar types, which are well known that are aggressive, and all the rest is embryonal. And we think that the problem is in the molecular biology, and as you know now, in the pediatric brain tumors, there are several subtypes, as in medulloblastoma, as in gliomas, and we think that also in rhabdomyosarcoma this is the case. But unfortunately, we don't have till now. They are working to have it exams in molecular biology for the rhabdomyosarcoma, and maybe after we will have answers concerning these patients.
Thank you.
Thank you, Professor Bakhti. Professor Azhari asked.
Thank you.
Comment or a question?
And congratulations for Moroccan Society and Naji and all the committee of the Moroccan Society of Neurosurgery. And thank you to give us the opportunity to see our friends, Olivier. Ça fait longtemps qu'on ne s'est pas vu. Bonjour. And the Professor Issam and Suad Bakhti also. It's nice to see you in this difficult moment. But I hope we will see you in few months.
I hope so.
Before we said few weeks, but I think it will take few months. Thank you, and congratulations for all the speakers for the presentation. Really, it was very interesting because pediatrics and neurosurgery is really not developed in many countries. I have one question for Olivier and one question for Suad. Olivier, we had 3 or 4 months ago, one boy, 11, left temporal cyst with vomiting, only vomiting. And we did ophthalmologic exam. It's not very disturbed. And we just put, my assistant put shunt. And after 4 weeks, he was good for 4 weeks. After 4 weeks, there is the recurrence of vomiting. And my assistant went for the revision of the shunt. I have been with him at this time, and there is no pressure, no CSF pressure, nothing. And the shunt was good. And just he make revision, and we let the shunt. And after 2 weeks, he has vomiting. And at this time, we make electroencephalogram, and it was epilepsy, which has resolved only by drugs, the vomiting. Have you the same case?
Yes, we have some.
One question for Suad, excuse me, Olivier.
Sorry.
For the edatic cyst, Suad, we had in CHU de Casablanca, Benorosh, the good series of orbital edatic cyst. And you are right, never, all the time ruptured. Because of the bone, he make a bone like a knife, and you can't dissect it. Because the ethmoid, all the time the ethmoid is effracted. And it's really like a very sharp knife. So small dissection and small manipulation, the rupture, but never recurrence of. We washed with the saline solution, and never recurrence of edatic cyst in orbit. Thank you, Olivier.
Thank you, Abdesamad. Thank you for your words. Yes, we have some very difficult cases, very difficult. but the case that you talked about, we have to be very, very cautious when there are signs, just one sign, and not as a sign of raised intracranial pressure. I think this time I will be not prompt to go to surgery. That's so. And it's difficult sometimes because you have the pressure of the mother, of the GP, of the parents. He or she doesn't look very well. She's vomiting. He's vomiting. He has headaches, and so on. But clearly, we have to be very, very cautious.
Thank you.
For edetic cysts, the edetic cysts that we have in our series are not so huge as you have in your experience, but even if they were if they were small, there was always adherence between the capsula and the muscles. And that's why we were obliged to make a rupture. It was not possible to resect in totality the capsula of the edetic cyst. And this is the main problem. It was not because they were huge, and we were afraid to have complications in these children that have not a lot of clinical signs. We were afraid about that. Concerning the recurrence on the both, we've had only one recurrence that has been reoperated. Until now, patients are quite well. We have remnant. We see on the CT scan remnant of capsula, or I don't know if fibrous tissue fibrous, or I don't know what is it, but they are doing well.
Okay, thank you.
Thank you, Professor. Yes, Professor Benzgemut, you asked to give a question, I think.
Yeah, thank you. Thank you, Fed. First of all, I would like to thank the three speakers for their excellent lectures. Then I would like to ask a question for Professor Klein regarding the natural history of arachnoid cysts in children. I mean their evolutivity or the size evolutivity and its relation to clinical symptoms. Have you any experience or have you follow arachnoid cysts in some kind of population, and what are the special types of arachnoid cysts who will grow with time? In our department, we have managed one case in 7-year-old boy which was followed 3 years, and it grew. The size of the cyst grow with time with orbital extension and causing exophthalmia, indicating surgery. I would like to have your opinion about the natural history of this cyst. Thank you.
Yes, thank you for your question. It is very important to follow these children and to follow clinically and radiologically by the best by MR or CT scan. As I said, Galaxy 1, they don't evolve, but Galaxy 2 can, and Galaxy 3 is very, very frequent. It's very important to check if there are orbital problem, extension of the cyst through the lateral part of the orbit, very, very important. And then to be prompt to go to shunting. Coming back to one other question. I said for Galaxy 3, we go for shunting, except for children less than 2 years. If they are less than 2 years, then endoscopy could be a very, very good option, and you can have the best results with sometimes complete disappearance of the cyst. So it depends on age. But this cyst must be followed. Galaxy 2 and Galaxy 3.
Thank you, Professor Olivier.
Sorry, he's asking to have the word. Professor Bouyoussef.
Thank you very much, Najia. My connection is very bad. Sorry. Thank you for this very, very nice webinar and very nice talks for the three authors. I have 2-3 comments about first about the shunt in the spina bifida. In our experience, we perform first ETV, and we have more than 50% of success rate in the treatment of hydrocephalus. It's very, very important. More than 50% of ETV are successful in myelomeningocele. Second comment about arachnoid cyst. The problem of arachnoid cyst is not only the volume. It doesn't matter for the volume. And the indication is clinical, radiological, and in the MRI we have a special sequence is ISL to see if there is hypoperfusion surround the cyst in the parenchyma, cerebral brain parenchyma. For the treatment, I think that when the cyst is near or close a ventricle or a cyst, is better to perform endoscopy for ventriculocystocysternostomy, for cystocysternostomy. But when the cyst is far from the lateral, from the ventricles and from the basal cistern, like the position, the convexity or in the posterior fossa, at this time we can put a shunt. But the majority of the arachnoid cysts are near the ventricles and the arachnoid cysts. The third comment for Suad for this nice, very nice presentation. Why in your team you have only women? I don't understand. Thank you. Thank you very much.
May I have a comment, Fed, about the comment of Kherdin? It's about you remember we had round table in Nouakchott this year in February of 2020. This year, and I think you have something, and you lost this meeting, and I reviewed the literature about the relevance of the ETV in the patient and the child with the myelomeningocele. And all the literature and in our experience also, it doesn't work. You are always telling us that you have more than 50% of the good result. But so sorry to say that and when we reviewed the literature and we reviewed our series in Morocco, it's not true, because you know very well better than me that when you use ETV in the baby under 3 or 4 months, it's first very difficult to to perform it for for the simple neurosurgeon, not the neurosurgeon as the Professor Khertin, of course. And the second thing is the Olivier tell that Olivier, I think, or Professor Shale told about that. It's the anatomy is different. It's very different in the small baby under 3 or 4 months. This is totally disagree with you. I'm sorry for that, but it's my opinion. Thank
you. Please, may I ask a question?
I have a question. Sorry. Yeah. Who is in Professor Khadam?
Yes, I wanted to ask a question in the same way, but I wait. You finish your question.
Just I finished. I have a question for Olivier. It's about arachnoid cyst. Sometime when I'm speaking about arachnoid cyst, when it is of course symptomatic, and we decide to operate, even we decide to do it endoscopically. Sometimes we have a bleeding, and it's very known. It's some case. How you can explain? I never find the just explanation for this bleeding in this arachnoid cyst. In some arachnoid cysts.
You mean Naja, a bleeding during the operation or on the post-op CT scan?
After. Yeah. Post-operatively, when you perform a CT scan, and there is sometimes some complications.
I think we have to wash before closing the cavity of the cyst, and that's what taught by Patrick Delem in Lille. I usually attach the dura to very yes, I'm very cautious about that, but we sometimes have such difficulties anyway, and we attach the dura at the time of when we're beginning to open it.
Okay, thank you.
I ask a question to all our guest speakers and Professor Youssef in the same way that Professor Abadi said about the efficiency of the ETV in hydrocephalus secondary to myelomeningocele. We know as under the 9 months, I think it's not efficient, and some teams practices currently subgallial, transient subgallial shunt and subgallial drainage of CSF, ventricular subgallial drainage. What is your opinion and experience about? So till the age of 9 months, and then we do ETV with the CP coagulation.
Just for waiting, it's not definitively
yes, transient.
Just for waiting.
Just for waiting. Yeah. But what are the experiences? Yes.
Can I come in here?
Yeah.
Have you ever seen ventricular subgallial shunt? It is horrible, actually, because the fluid will be collecting under the scalp, and the head of the baby will be squishy. You know, it's horrible. I know for premature babies who has hydrocephalus, and you want to buy time, and this time will be the baby will be kept in the NICU, the neonatal intensive care. That's fine, instead of tapping the ventricles. Although tapping the ventricles is not bad, because you don't need to do it very often. Maybe once or twice a week. That's all what you need to do. It depends on the head circumference growth. But the family coming to see this baby with his head this big and squishy, it's a scary feeling. This is how I look at it. I can use it as to buy time in those premature babies, but not for the spina bifida, for sure.
Thank you.
So, for the question about the age, as we shown in our conference about endoscopy, we shown that the bad results is under 3 months and when there is hemorrhage. We show that for more than 3,000 procedures. In spina bifida, more than 1 year, more than 6 or 9 months, ETV is very well doing. I told you we have hundreds of cases. And I know that in the literature, many people said that ETV doesn't work good. But in our experience, if the patient is more than 6 months, and generally the baby come to the neurosurgery department late, and he's more than 3 months, if at this time the result is very good. And we can wait, as said the Professor Lakhdar, we can wait. I don't have any experience with the subgaleal treatment, but is very well known in the literature. We can put a shunt to the galeal surface, waiting that the patient will be more than 3 months. I agree with you.
We are speaking the same language, Khairuddin. I'm telling about the children under 4 months, of course. But of course, over 6 months is different. The problem is really different. Totally agree with you.
Professor Bakhti, maybe you have a comment?
Yes. I just want to make a comment and also to ask Professor Shail and my friend Olivier. First of all, I just want to return to the problem of shunting before, during, or after. Our policy currently in the department is to shunt systematically if the baby needs a shunt. And of course, I'm talking about young babies because we receive more and more very young babies under 3 months. So if we have a huge dilatation, ventricular dilatation, what we do is we put an EVD during the surgery for myelose. Because we are always afraid, and of course, the babies will come after 10 days after birth, or 1 month, 2 months, and we know that infection, the skin is already infected. So we are afraid about infection of shunts. So we put an EVD, we wait 10 days, and we exclude all the signs of clinically and biologically signs of a potential infection, and then we can put a shunt. We are also very strict about the shunt. So if we don't have important signs of intracranial hypertension, we do not put a shunt, even if we have a ventricular dilatation. And if we receive the patients during the first days of his birth, if the hydrocephalus is very important, we make simultaneously a shunt with the repair of the myelomeningocele. This is our policy. And of course, as you said, Professor Shail, the problem is a lot of children with myelomeningocele doesn't have cognitive problems. And if we add the problems of shunt infection, we will have these cognitive problems, and we will aggrave his quality of life in the future. The first question that I want to ask you, Professor Shail, is you have put a slide with 63% of diagnosis at birth. What is the explanation? For example, in Algeria, yes, we receive quite lately the patients, but most of the diagnoses are made during the second and the third trimester before delivery. So this is the question. And for Olivier, I'm totally agree with you about epilepsy. We never put an indication for surgery in these cases because we know that it is maybe a cause of the gliosis around this arachnoid cyst. But my problem in arachnoid cyst are the asymptomatic arachnoid cysts, huge asymptomatic arachnoid cyst in children who are making, for example, a lot of activity of sports, for example. And I have this dilemma, should we operate him? Should we wait? This is really, what is your experience in this field? Thank you.
You allow me to start? Well, great questions, Surat. Thank you very much, really. About this 60%, the reason is these data were collected over the past 20 years. So at that time, we did not have that great ultrasonographers. Antenatal ultrasonographers are very well-trained technologists that they can pick up the details and they can say, they raise the flag and they tell you there is a problem with the baby. They will look for a radiologist. If not, then they will transfer the patient to a place where they can interpret this. And that's the difficulties why, despite that we have antenatal surgery program, until now we haven't gotten a case that we can operate on the baby for a repair of a spina bifida because they are not picked up early. Now, things are changing, I must say. In Saudi Arabia, more and more cases are coming early. And even sometimes we are even discussing abortion if this is before the 16th week of gestation. So that's how far we are now. But the data we had is for patients where at a time where we did not have enough ultrasonographers to pick up these changes. That's the explanation.
Thank you.
Thank you, Professor Issam Sheikh. I don't know if there is another question. I have
Fahd, Olivier doesn't
yes, sorry, yes. Sorry.
Thank you, Fuad, for your question.
You are tired, huh? You are tired.
Sport. We just discussed in our staff a couple of weeks ago of this problem, and in the literature review that we did, there is a nice paper published in Journal of Neurosurgery Pediatric from Jennifer Strahl in 2016. And the conclusion was there is no reason to limit sports to these children. So, and in addition to that, the rupture, the phenomenon of rupture of the cyst is not proportional with the trauma. We saw sometimes it from minor head trauma, and sometimes we discovered an arachnoid cyst in children with following a traffic accident, very violent, and there is no rupture. So I have no restriction talking about sport for these children. Also, I know that it is debated, but that's our policy, our philosophy in Nancy. And talking about very wide cysts, huge cysts, I recommend surgery, even asymptomatic. Maybe you can follow them one or twice, but it is not unlikely that these cysts progress during time.
Thank you, Olivier. Thank you.
Thank you, Professor Olivier Klein. We have some question on the chat, on the conversation window, and one question is: do we have a radio for Professor Klein? Do we have an radiological opportunity to differentiate temporal lobe agenesis from arachnoid cyst? I think you have already answered this question.
Yes, yes, it's quite easy to make it with our neuroradiological tools and MR, and yes, we can do it sometimes with a CT scan.
Okay, another question for Professor Essam, is a colleague from sub-Saharan country. Is because of, he says, because of hydrocephalus following the spinal dysrhythm, he operates first for hydrocephalus and months later spina bifida. What are your practice and what is your opinion?
Well, that was practiced in the past, but I think we came out of this approach. But of course, the handling those patients it should be directed at the situation. This doctor or this neurosurgeon or this surgeon is practicing. So I really wouldn't suggest otherwise, because I really don't know how things are in the sub-Saharan desert. And if they think it is easier to shunt the patient and then do the repair, then I would respect that. But I really don't do that, honestly speaking. I think the proper way is you close the defect and then you shunt the patient whenever they need. That's the trend of the patient, the people. Because, you know, if you put the shunt in and the patient doesn't need it, then he's shunt dependent. You converted that patient to be shunt dependent, which is something really not a very good thing. And many people are coming out of this practice.
Okay. Yeah, I just have one comment in our practice in Rabat. In our department, the oldest baby is less than 5 or 6 days when we receive this baby. So what we do is we shunt if we need to shunt an hydrocephalus, and in 2 or 3 days after we close the defects. This is how we do it in our department, and so now we don't have we have good results. We're just afraid that good results about liquid, but not for the patients. So I don't know what if I don't if we can do close the defect without doing the VP shunts. Maybe our results maybe will change. What do you think? It's good. Please, Professor Essam, can you unmute your mic?
Of course, it will change, and I'm sure it will change. And that's why it is important also to start collecting these cases and following them. And you can ask how they're doing in the school, how they are performing. Because those patients, they survive long. They are actually the most surviving patient with brain or CNS abnormality, congenital deformity. And if they survive with poor cognitive function, they are really horrible on their patient, on their families, and in their society. But if they survive at a functional state, then perfect. This is exactly what we can offer as physician. We cannot really correct what happened, but at least we can make sure that the patient can live a decent life and function in his society.
Thank you, Professor.
May I have a comment?
Shail.
May I have a comment?
Yes.
Yeah.
Yes, go ahead.
I think that we had a nice session dedicated to pediatric neurosurgery, and we know that a childhood population in our countries is still, unfortunately, a huge amount of our population. It was said by Najia that we see in many of our countries that pediatric neurosurgery is practiced by almost all neurosurgeons, but fortunately there is some colleagues who are dedicated to pediatric neurosurgery. We have seen the nice team of Suad in ITD in Algiers. Our guest today, Dr. Isam, is the chairman of the Pineal Pediatric Neurosurgery Society. So I think that my appeal to him and to Najia, who is the president of the Pan-Arab Neurosurgical Society, is to try to encourage and to gather these teams of pediatric neurosurgery who are existing already in different countries. We had in Morocco at least 4 or 5 colleagues who are doing more than others pediatric neurosurgery. And of course, to try to organize it more. We have seen through the topics of today that there is a great need for these colleagues, and that pediatric neurosurgery is quite different in many aspects from general neurosurgery. So I hope that we can move in the future, of course, with the coordination of Dr. Isam and Dr. Najia regarding this development and encouragement of pediatric neurosurgery.
Thank you.
Thank you, Professor Khamdishi,
Maybe
for your always your. Please just give me just 1 minute to thanks for first Professor Khamdishi for his suggestion. It's a really very we need today to have a pediatric neurosurgeon, and we know the difficulties that we have, all of us, in the especially in the Africa, even in North Africa, even if the development of neurosurgery in these countries of North Africa is well, but to have department of neurosurgery, or at least unit of pediatric neurosurgery, is in my opinion is the good way that you have to follow. And your suggestion also to work with the societies, pediatric societies of Pan-Arab societies. Maybe there is a small society of cancer pediatric, which is by our friend from Egypt recently. I think we need to gather our help and create something for future to take in charge correctly this pediatric patients.
I don't
so
know.
I think you have something
here. I don't see him.
Yeah.
Dr. Isam, maybe he's gone.
I think he's here. Don't worry, I will send him an email about this conclusion, and I will, you know me that I'm temporary. I will push in this way. Don't worry, Professor Khamdishi, you know that I will do it. Fahd, there is another question from the audience, from the participant.
I don't have
where is
our I don't have
Professor Nabila,
yes, there is a question from. Good evening, Dr. Adab.
Yeah, sorry for my cam have some trouble. I may ask Dr. Professor Suad Bakhti. First, good evening, all you professors, for the great presentations, and we are very appreciating sharing with us the incredible experience you have done during your career life. So, to make it brief, I know we are all tired. Professor Suad, I do really feel very proud of you actually for the tremendous work you have done with those incredible orbital cases. My questions, Prof, would you consult for an ophthalmologist to help you in the surgeries or a maxillofacial surgeon, or would you do those cases by yourself from A to Z?
All the cases of the series were done by the neurosurgical team. I must say that 2 exenterations were done with Professor Gemry from ophthalmologist because they were her patients and she couldn't operate them in her department, so she come in our department. But all the cases that you have seen were operated by the neurosurgical team. And then I explained that I have some problems with craniofacial teams. Till now, I can't create a group for that. And unfortunately, our ophthalmologist doesn't deal a lot with this kind of surgery. They are dealing mainly with angioma or small lesion in eyelid. But when it's concerned the orbit, it is the neurosurgeon in our country.
Okay, thank you, Prof. My second question is in brief. Actually, I've never seen such cases during my residency and my initial practicing currently. So would you give us a number for how many cases you can see like per year? Is it very common to have those congenital or orbital malformations in your country?
You are talking what malformations? Orbital malformations or what?
Yeah, the orbital lesions and all.
You know, I can't give you per year, but you know, and I'm not. Our department is not the only one who is dealing with orbital lesions. There are several departments who are dealing with this. So I can give you a real incidence. What I know is that the cases that I have shown are very rare. Not all our colleagues have these cases. I think in Babelwed, which is another department, they have this kind of lesion, but in other departments, they have small lesions. Fortunately, we have more small lesions, but unfortunately in my series, for the 35 patients, you see that I have a lot of these monstrous cases. I can't give you a real explanation because maybe there will be many bias. I know, but what I'm sure is that for young infants, I think that all of them are referred in our department. When I talk about young infants that are under 2 years.
Okay, thank you, Professor Saad. Thank you, Professor Nabila.
Maybe Suad is asking how the percentage it represents this orbital lesion in the brain tumor, for example, in a pediatric.
I didn't make this, you know. I have the percentage of children inside the series of orbital, but I will be honest, I didn't make the percentage among brain tumors because I consider that totally different. So I didn't do that. Maybe we will do that after.
Maybe.
Yeah.
Okay. Thank you, Suad.
Thank you,
think
Dr.
it's
Professor.
there is. Thank you, Reda.
Thank
you
you
for your question.
I think it's time to conclude, and may I ask Professor Abdelhakim Al-Khdar, our president, to say the last word of this webinar. Thank you.
I will thank our guests for their interesting talk, Professor Saad Bakhti, Professor Olivier Klein, Professor Shail. Also, I will thank all our panelists and Professor Al-Abadi for maintaining this program, and Dr. Darqawi and all the attendees. And I hope we will meet next week, next Thursday. Thank you.
Thank you, Professor Khadar, and have a nice day.
So much to all our
Bye-bye, everybody. Have a good night.
Bye. And see you
Bye-bye.
next week. See you next week, inshallah.
Inshallah.
Et très bonne fête. Très bonne fête.
Merci, merci, merci. Thank you.
Thank you very much, everybody.
Thank you. Thank you, Professor.
Bye-bye.
Bye. See you.
Bye.